everyone is getting vaccinated and staying healthy. We're really glad you're able to join us today for what's going to be a busy session with a lot of exciting work that we have to share with you all today. So with that, I also want to introduce our co-chair, Dawn Herfin.
So yeah, thank you so much. Thank you all for joining. We have close to 150 people on so far, and it's only 4 minutes in, so we're super excited about that. I want to welcome you all. We're keeping our fingers crossed that the meeting in the fall will be some type of hybrid session. Just as a bit of introduction, we changed the order around a little bit from the agenda you may have gotten. The first three presentations are going to focus on studies that are just about to activate or are in the process of undergoing concept review or grant submission. And some of these we want to get feedback on. So there are some audience participation questions mixed in there. So I think without further ado, we can start with our first presentation by Veena Shankaran on S1912CD. I guess we can advance the slides. So take it away, Veena.
Hey, thanks, Dawn and Scott, and thanks everyone for being here. I will try and keep this relatively brief because we actually do have a kickoff meeting for this study credit study at 11 a.m. Pacific, 1 p.m. Central, 2 p.m. Eastern, and there's a slide on that a little bit later, so it has all the details. So if you're interested, please, in hearing more details, please join that meeting. Next slide. So just by way of brief background, many of you are familiar with S1417CD and the topic of financial toxicity in general. We're now realizing that this is a very prevalent problem that affects patients across socioeconomic strata. And not only that, but affects a number of patient outcomes as well as caregivers. And so I think there's increasing recognition that we need to think more about interventions to address financial toxicity, and also that these interventions ought to include patient caregivers. Next slide. So over the course of many years, we've conducted some pilot studies with our financial navigation and counseling partners in the community, Patient Advocate Foundation and Sense, to develop a proactive financial navigation program, which we are planning to implement in this study and determine if this program actually decreases the risk of material financial hardship in patients and spouse caregivers, which we're going to be measuring using credit data. And we're going to be looking at a number of other outcomes in both patients and caregivers, quality of life, financial worry, caregiver burden, healthcare utilization, and treatment adherence. Next slide. This is the basic schema of the study. So we will be enrolling patients and spouses as a dyad. The dyad will then be randomized to either a control or intervention arm. In the control, the dyads will receive financial literacy training, which will basically be a series of online videos. In the intervention arm, the dyads will be receiving those same videos along with financial counseling, indirect and non-medical cost assistance, and then healthcare coverage assistance from our 2 financial navigation partners. That intervention will continue over the course of 6 months. And then all participants at baseline, 3 months, 6 months, and 12 months will complete surveys, and we're going to be accessing their credit reports at these times as well. Next slide. So in terms of eligibility criteria, first we're going to be enrolling 536 dyads, or 1,072 study subjects. In terms of the patient inclusion criteria, so all patients greater than or equal to 18 years old who are within 120 days of a metastatic solid tumor diagnosis requiring treatment or hematologic cancer diagnosis requiring treatment will be eligible. We are not including people with hematologic cancers that are just on surveillance or watchful waiting. They have to be actually on some kind of therapy. And we are allowing patients who have recurrence of earlier stage solid tumors, provided that they are now being diagnosed for the first time with metastatic disease and that the previous diagnosis was 6 months prior or earlier. We're allowing both English or Spanish speaking patients, and all of the materials in the study will be translated into Spanish, and we will have case managers and counselors from our partner organizations who are Spanish speaking. And then in terms of the caregivers, we are including essentially any caregiver who is a spouse living with the patient and either illegally married or filing tax returns as married, filing jointly. Next slide. Here are just some additional inclusion criteria for the patient. We basically there are some specifications around the treatment. So treatment can be initiated within 60 days prior to registration, or patients may not have started treatment yet, but be scheduled or planning to start treatment within 30 days after registration. And we're allowing people to be enrolled on other clinical trials. Next slide. So in terms of status updates, I think the anticipated activation date is still a little bit in flux. We're anticipating in May, so by next month, hopefully, with the first participant registered shortly thereafter. And ideally within shortly thereafter, the first group of Dyads receiving the intervention from our partner organizations. Next slide. So here is the information on the kickoff call that's happening this afternoon. And I think that, actually, I'm not sure how where the call-in information is for those of you who aren't signed up, but just go ahead and email me if you need information. I'll figure out how to get that to you. Next slide. And I just want to acknowledge the investigative team, everyone who's worked really tirelessly to get us to this point, and in particular, Barbara Segarra-Vasquez, our patient advocate, and our collaborators, PAF and SENSE. And I believe we will have representatives from these organizations on the kickoff call this afternoon. Next slide. So just feel free to email me anytime. And I do want to mention that we do have for patients who are, for sites who are enrolling patients, there is a study team email, credit@fredhutch.org. So just feel free to email us with any questions as well. And that's all I've got. Happy to take questions if we have time.
Thanks so much, Veena. Are there any questions from attendees for Veena? As she mentioned, there's going to be a devoted session to this study later today, and we hope that folks who are interested will be able to join Veena for a more detailed discussion of getting credit started.
Yeah, and anybody who's interested, you can, if you just go onto the SWOG link, it's a general link to get into this, so you don't need any kind of special permissions. So you can either email any of us and we'll send it to you, or you can go onto the SWOG website and for the meeting website and get the information that way. Because of the way these WebExes are structured, if anybody has any specific questions, you have to type them into the chat box. So I don't see anything. I don't know if there's a delay. But if anybody has any specific questions, please join the kickoff meeting. I think this is, we've seen that this is a huge issue. This is, I think, one of the first randomized intervention trials for it. It will definitely, lead to, a change, potentially lead to a change in practice. I do see one question here. is the PAF intervention similar to what they now offer to the public?
Yeah, it's similar. So it's essentially all the services they normally provide. What's different is that they're actually proactively contacting the patient and caregiver and offering the assistance, whereas, you know, as opposed to the normal process where people have to contact them.
Great. So I encourage everybody to join the kickoff meeting and to open this trial once it's activated. I think we can move on to the next presentation. So I don't know, Magna or Jens, which of you is going to be presenting?
I'm going to present. This is Magna.
Okay.
Should I go ahead and get started?
Yeah, that would be great.
So I'm going to present on behalf of me and Jens, who's also on the panel here. So this is a study idea that we've discussed in the past at several of the other committee meetings, but this is a new concept that we recently presented at the DCP Steering Committee. It is S2108CD, a cluster randomized trial comparing an educationally enhanced genomic tumor board, or eGTB intervention, to usual practice to increase evidence-based genome-informed therapy. So just brief as background, you know, the use of large panel genomic testing is increasing, and there's a large gap in the ability to, our ability to detect variants and the ability to assess and apply that information. And oncology providers also have a wide variability in their competence and knowledge about using this. There's been preliminary data from the Maine Cancer Genomics Initiative, which is led by Dr. Reuter, who's the co-PI on here, showing that this intervention can help physicians in their practice of interpreting and applying this information. So in this study, we are going to randomize 16 NCORP sites to either receive the eGTB intervention, which I'll describe in the following slides, versus 8 sites that are randomized to their usual practice. And our primary endpoint for the study is going to look at the proportion of patients who are started on evidence-based genome-informed therapy at 6 months. Throughout the course of the study, there will be surveys for the physician providers, and from the patient perspective, they are signing consent to allow us to review their medical record. The key eligibility criteria, so there are basically 3 levels of eligibility: the participating at the level of the site, the level of the physician, and the level of the patient. For the participating sites, we're defining a site as an outpatient clinic or group of clinics that belong to the same NCORP, MU NCORP, or subcomponent site who will be contributing patients to this study. They should be able to enroll 2 to 3 patients per month into the study, and we're really looking to look for sites that are rural, community, MU, NCORP sites that have limited access to these resources, that may not have an existing, a pre-existing GTB, sites that need access to this type of resource. From the physician standpoint, it should be a physician or a medical oncologist, gyn-onc, or neuro-onc who's willing to attend and participate in the genomic tumor boards where their cases are going to be presented, and they offer this study to their patients. And then from the patient perspective, it's patients who are diagnosed with advanced stage solid tumor malignancies who have genomic testing results that are available, and it's anticipated that they will need a change in their course of treatment over the next 6 months of enrollment. The entire study period will be over 24 months. We can go to the next slide. So this slide shows the study objectives and endpoints. So the primary objective, again, is going to be to determine whether an eGTB intervention compared to usual practice increases the proportion of patients who will receive evidence-based genome-informed therapy. And that will be measured by the PIs, the investigators, at the end of the study, and we will look at all of the various treatments received over the 6-month period, and we have strict criteria based on the ASCO AMP-CAP guidelines for level of evidence for genomic-informed therapy, and we will determine if any treatments received are consistent with evidence-based genome-informed therapy. We also have several secondary objectives looking at physician genomic confidence attitudes, looking at the clinical outcomes of the patients, including overall survival and time to treatment failure, and then also looking at physician interpretation of variant actionability. And then finally, we will also have an implementation objective to look at how this intervention can be implemented into clinic workflow and to better understand the barriers and facilitators. And we'll be using metrics from the CFER framework in order to assess these endpoints. Next slide, please. So the eGTB intervention itself is really made at, it has two components. One is the structured GTB, where the goal is to prioritize treatment options and help give physicians a framework to think through the genomic testing results. And it is administered as an organized, moderated discussion of a patient's GTT results, including the clinical implications of the variants, the evidence of utility of the treatment, and then personal clinical experience with the treatment options. And so the table 1 on this slide kind of goes through what these components are. The goal will be to have structured GTBs, once a week over the course of a month at various different times through the day to make it accessible to sites across the country, so that time zones are not so much of an issue. There's also a supporting education component where there will be educational resources available online, and these are designed to support decision-making using results from genomic testing. And table 2 on this slide shows what some of the topics are. So looking at evidence of the clinical utility of genomic testing, benefits and limitations, the framework for looking at results, and then, of course, clinical utility data and evaluation for clinical trials. Okay. The next slide, please. I just wanted to also kind of touch upon what the commitments would be from the site. The clinical research coordinators, they would be responsible for data entry for the patients and from the physicians, coordination of the eGTB intervention at the site, of course, in the intervention arm only, and then participation in some of the implementation measures, so interviews and questionnaires. We are asking for a physician site champion at each site who will supervise the study activities and who will attend or delegate a representative from the site to attend the structured GTBs for the cases from that site. Again, that will be for the intervention arm only. And then, again, also participating in some of the implementation aims. The physician participants from the site will be asked to complete surveys regarding their individual patients who are enrolled onto the site, and again, also will be asked to attend or delegate a representative from their site to attend the structured GTBs for the cases for their site. So, we understand that oncologists and the physicians participating are very busy. We would, if they can attend or delegate someone from their clinical team to attend the GTBs where their cases are being presented, that would be great. They are also able to attend any of the GTBs if they want to for their own knowledge and understanding, and we would, of course, welcome that. The patient participants, they will just be signing a consent to allow for review of their data and medical records. There's no surveys or any other measures that they need to complete. Next slide, please. So with respect to feasibility, so again, the Maine Cancer Genomics Initiative has demonstrated in a pilot study that this is a feasible intervention. Again, we're looking for a total of 16 sites, and based on kind of the preliminary work we've looked at, it looks like there are over 200 sites that would be eligible to participate in this study. And we are, again, I'll emphasize, giving priority to those sites who may have limited resources to such genomic tumor boards. They don't have an existing tumor board and are in rural or community practices. There's no minimum number of physicians per site, but they should be able to contribute 2 to 3 patients per month to the study. And additionally, we do have STRS grants to support some of the financial
Boy, I think we lost Magna's audio.
I think we lost Magna's audio.
Disconnected. Can you hear me now?
Yes. Yeah.
Sorry, I don't know, my phone cut out on me. I'm not sure why that happened. Sorry about that. I'm not sure where it cut out.
You were just talking about the SWOG trial support, Magna.
Okay, all right.
That's where it stopped.
Okay,
Yeah.
so I figured it out soon. Okay, so the grant will help support the cost of personnel and administrative needs for the tumor board. Next slide, please. Just to emphasize what the impact or significance of this is. So this will allow us to give a rigorous evaluation of the impact of this type of intervention on the use of evidence-based genome-informed treatments in cancer care. It will give us some important preliminary data on the implementation with respect to the barriers and facilitators of establishing this intervention across community sites, and eventually will inform the development of a larger study of dissemination and implementation of this intervention as a way to broadly incorporate precision medicine into clinical care. And our hypothesis is that exposure to this intervention will improve physician decision-making, increase evidence-based genome-informed therapy, and ultimately improve patient outcomes. Last slide, please. So again, we did just recently present this at the CCDR steering committee. We received a ruling of pending, and so we're waiting for the feedback. We're very eager to move this forward, and as such are really looking out to see which sites will be interested in participating in this study. And I think there was supposed to be a poll question here. I don't know if this is an older slide or not, but oh, here we go. Perfect. So, we are interested in knowing, number one, would your site be interested in participating in this study? If you could answer yes or no. And then if yes, please put your institution name in the poll question. Please feel free to reach out to Jens and I. We're happy to tell you more about the study, any questions you may have. And again, we're really excited to be moving this forward and looking for sites that would be interested in participating.
Great, thanks.
So Magna,
sorry, go ahead.
go ahead.
I was going to say, Magna and Jens, for the great presentation. This is another study that we think could be practice changing. So we're hoping that a lot of NCORP sites will be interested. There is one question from a panelist. If a site has the ASCO taper study open, can or should they consider opening this trial?
I think it would be great, that the taper study, at least from the perspective of offering clinical trial options for the patients, would help. Jens, I don't know if you have anything else to add.
Well, I think it's an excellent question, and I think the answer should be a resounding yes, because what these, the taper specifically is a really good complement to this trial, because it has treatment options for the patients, but it also requires a little bit of finagling as to whether or not an arm is open or a cord is open. There's a little bit of work that needs to happen sort of before you enroll a patient on taper, as I'm sure you know. So I would highly encourage that if you have taper open, to open the study.
Yeah, I mean, just to reiterate, taper allows you to get drugs that may be off-label. So in order to know which may be appropriate or inappropriate drugs to get, it's that's a possibility, but please fill this out. I think it's important to know that some of our large NCORs may be multiple different sites. You may be divided up into multiple different sites. It may not count as one site, it might count as multiple sites. So please put that in. They're going to reach out to sites to get that information. It looks like there were 18 sites that, at least on this call, that seem to be interested. We're going to have Jens and Magna reach out to each of you individually. I know that some of those are large and maybe multiple sites. I want to also say that we had a call yesterday, our NCORP PI call, and we asked some sites about their interests in participating in site randomized trials. And the overwhelming response was that the sites really liked these cluster randomized designs, that they liked participating in these studies. They weren't overly work intensive. It made it much easier to accrue patients because they knew ahead of time which arm they were in, because it was a site randomization. And so the team is going to work very, very hard to make it as easy on the physicians and practices as possible. But if any of the, I'm assuming most of the no's already have tumor boards, or maybe on the fence, or not 100% sure. If you change your mind or are interested in any way at this point, reach out to Meghna and Jens. I think they want to try to clarify all of the sites before resubmitting the concept to the NCI. So definitely reach out if you have additional questions. I don't know if Meghna, Jens, you have other things you want to say?
Well, I just want to, there's actually a follow-up question about taper, and actually I wouldn't mind answering that because it's a very good one. So the question is about taper providing access to a genomic tumor board. Actually, they call it a molecular tumor board, and that is true. However, and I know this firsthand because we have the taper study open in Maine as well. The taper molecular tumor board is specifically for to make a decision in the case there is a non-perfect match for a patient in the matching algorithm that the EDC system provides. So it's a very specific function. And so only a subset of patients that have genomic tumor testing will ever get to the taper molecular tumor board. So I think that this intervention actually is helpful because it comes essentially upstream of taper. You would get some additional insight into taper without having, or you would get more insight into the molecular test report and the genomic test report before even considering taper enrollment. So I think that's why it's a good complement, but it's a very good question about the interaction between taper and this study.
This is Don. If I could for a moment, I do think we need to talk more about that issue of taper because we don't want to contaminate our evaluation. So it's a bit of a complex issue. I'm glad folks raised it.
It looked like 18 sites said they were potentially interested, and if anyone didn't get a chance to complete the poll before it shut down, we'd really encourage you to reach out to Jens and Meghna and just indicate interest. It would be helpful for them in the short term because they're trying to show NCI the level of interest, but also, of course, for them when they get going, which we hope will be soon. So let's turn over to our next study concept, impact of an OAC medication practice model using RapidPro. Karen, will you be presenting?
This is Emily. I think I'll get us launched and Karen will add in when she can. Great. Can you hear me okay?
Yes.
Okay, great. Thank you, and thanks everyone for being here. So we are presenting or sharing with you the concept of an impact of an oral anti-cancer medication practice model utilizing RapidPro, and this is a pragmatic trial. Next slide, please. And so we want to share some aspects with you related to kind of the rationale of this, but first, some of the background experience related to this. Karen and I have had the opportunity to implement a practice change model within the state of Michigan through our work with a collaborative called the Michigan Oncology Quality Collaborative, where we've worked with practices across the state in improving specific quality-based measures in the care of their cancer patients. And our intent is to expand the model that we've implemented across the state and our learnings from that to support practices throughout SWOG. And this is the main point or the gap that we've seen. We want to support practices in really the routine monitoring of patients who receive oral anti-cancer medications and to see if this model helps to improve patient outcomes. Next slide, please. So again, we are looking at how we can implement something that can be used routinely on a clinical day-to-day basis to monitor patients receiving oral anti-cancer therapies how we can help support practices in the monitoring of this patient population related to their toxicities, as well as how, based on that monitoring, we can help enhance or improve their medication adherence. One of our learnings, which I know we presented previously to this group, but in what we learned across the state of Michigan, was that we still had quite a high number of patients identified who receive oral anti-cancer therapies who were found to be non-adherent to their medications. That was almost 30% of patients who self-reported on adherence. And the primary reason for this patient population reporting non-adherence was related to side effects, either experiencing them, having difficulty managing them, or fear or concern about side effects coming up. Much of the published data related to improving medication adherence in this patient population is typically specific to either a disease state or a particular drug class. So for instance, information about optimizing adherence in CML patients, or with specific tyrosine kinase inhibitors, or in an endocrine patient population for breast cancer. So again, this project, the goal is to really look at how we can enhance the care of the patients as a whole by using a routine process improvement within this care of the population. Next slide, please. So since we spoke last to the group, we've revised aims on just really wonderful feedback that we've received, and being thoughtful about what would be the most realistic when we roll this out on a larger scale. And so our first aim remains that of looking at how this practice model can impact the patient outcomes. And so we're looking at how the practice model impacts treatment failure and health-related quality of life at 12 months for patients receiving oral anti-cancer therapy. You may recall in our last presentation to the group that we really looked at more specifically medication adherence for this primary outcome, and we have since revised that based on the fact that this practice model looks at routine symptom assessments and monitoring as well as adherence monitoring. And treatment failure takes into account considerations of treatment failing because of toxicity, because of non-adherence, or other progression that can occur. And so we thought this was more encompassing. We also modified slightly from an implementation approach to a pragmatic cluster randomized trial. And so our hope is that this trial would occur within 24 NCORP sites, with approximately 45 patients per site for those who are randomized to take part. So it would be 12 that are receiving the practice model and 12 who are our control group. We also, as a secondary aim, would like to characterize facilitators and barriers of adoption of the practice model within our intervention group, and then finally examine the time varying and thresholds of rapid pro factors on the OAC outcomes. And the next slides will go into more detail on all of these aims. So next slide, please. So for aim 1, again, this is a pragmatic cluster randomized trial. Our participants would be 24 NCORP sites. We'll talk again a bit in the next slide about enrollment criteria. So 12 of these sites will be intervention, 12 control, with approximately 45 patients per site. The intervention would be a 12-week practice change to implement the practice model. The primary outcome would be treatment failure, and the composite defined as treatment change, treatment discontinuation, progression, or death. And what our hope is a reduction in outcome by 10% would be expected in the intervention group. In addition, we'll be measuring health-related quality of life using the PROMIS scale, data collection. And so just to make sure that this is clear in the discussion, data collection on the research end will occur for the practice characteristics at baseline in 3 months, for demographic and clinical characteristics at baseline in 12 months, and then the patient-specific measurements of the Rapid Pro, which is a patient-reported outcome tool that we are implementing, as well as Promise, would occur at baseline, 2 weeks, 1 month, 3 months, 6 months, and 12 months. And we would utilize chart abstraction for looking at the treatment failure. I want to note in this section, and it will be illustrated again further in another slide, however, that patients will, as part of the intervention, also be completing some of the Rapid Pro surveys as their clinical follow-up within the intervention. Next slide, please. So for the design, we will be looking at sites to see if there's an existing oral anti-cancer agent program that already is in place that specifically proactively and routinely assesses patient symptoms within the first month of treatment. So one of the launching points of this model is that we have proactive outreach to the patients at approximately 2 months or 2 weeks after start of therapy. And so that would be something we're assessing with the sites who would participate. In addition, we'll be looking at some other inclusion criteria related to a standard number of oral medications prescribed per week, the willingness of the site to have a practice champion defined to help implement the practice change model, and really the practice's own willingness to use our link for patients to report on their symptoms and adherence. So the link to use the PROM and how they would receive that information back and hopefully incorporate it into their practice. So those practices that meet criteria will then be randomized to receive the OAC medication practice model intervention, where our team will meet with the practice champion and the practice administrator who's involved in the rollout of this plan. Our goal would be to enroll approximately 45 patients per site in looking at the primary outcome. And in addition, for this intervention group, we will be assessing facilitators and barriers with some additional surveys for those participating. Next slide, please. So our aim 2 is a practice level aim where we're hoping to characterize facilitators and barriers of adoption of the OAC medication practice model. We will be looking at both quantitative and qualitative measures in this assessment. And our goal with this is to collect some interviews from participants and patients, and as well as describe characteristics when assessing the feasibility, acceptability, and adoption. Next slide, please. Finally, our aim 3 is to an exploratory aim of examining time varying and thresholds of the Rapid Pro factors, which include in this Rapid Pro patient reports on their symptom burden, on their confidence in self-management, and self-reports of adherence, and to see how that relates to the OAC treatment failure and health-related quality of life. So this, of course, would look at the patients who are being monitored and followed and see using a random effects model, how we would explore mediation and moderation, predicting the treatment failure and health-related quality of life based on the collections of symptom burden, self-management, confidence, and self-reported adherence. Next slide, please. And this is quite hard to see, and this 12-week implementation includes the intervention and all the components. This will be simplified for presentation for participating practices, as this intervention and implementation plan is really for the research team, but does summarize all of the collection points. The model very simply is having a patient begin therapy with their oral anti-cancer agent, receiving planned education by the practice, and then having scheduled times of submitting a PROM, a patient-reported outcome, that does again collect on symptoms using the ESAS scale, 2 select confidence questions, and then self-reported adherence. Based on the findings of the patient-reported outcome, clinician outreach will occur to follow up and help manage patient symptoms and reports of lack of confidence in managing or decreased medication adherence. There are patient-level outcomes that we'll be looking at, really related to treatment failure and quality of life, and practice-level outcomes will be related to facilitators and barriers of adoption. Finally, we are curious and would like to learn if the PRO has any direct indicators with what patients are reporting with our primary outcome measurements for the patients. Next slide, please. So we have a few questions for all of you as we're moving this project forward and looking at our ability to expand the rollout of this practice model. I believe there are also some polling questions related to these, to a couple questions, and I'm not sure if those can come up as well on the side here. So one question is, do you or your practice have an oral chemotherapy program in place already that has outbound calls scheduled to assess patient symptoms between 1 and 3 weeks after starting their therapy? Or have you implemented a process already where patients are completing PROs as part of their symptom follow-up for oral anti-cancer therapy? So that's the first polling question. The second polling question is to get a sense from the audience and the practices if a patient reimbursement of $20 per month for 12 months seems reasonable, knowing the amount of surveys that the patients would be completing, both patient-reported outcome surveys for practice and clinical care, as well as the additional surveys I mentioned too that we would be looking at for the research outcomes of this project. So those are our 2 polling questions. While you're completing those, Karen and I have some additional questions just related to what the sites think currently about the inclusion and exclusion criteria of practices, if you think it's reasonable and what you think the collection would be, and any other concerns really about the aims that might come to mind. So I will open it up and look in the chat for some of these questions, and also have Karen add any additional comments that she might have or questions that she was hoping that we could ask of the audience.
Thanks so much,
Hi,
Julie.
This is Karen. Can I just clarify one thing?
Sure.
Or add to? It's not really clarify because Emily said it, but I just want to make sure that the audience follows what Emily and I are thinking, in that the intervention involves the Rapid Pro. So the practices need to administer Rapid Pro at 2 weeks, at 1 month, at 2, 3, like every month, so that you're getting that information to use in daily practice to understand what your patients are experiencing and how to support them. Okay, so that's what's going on in your clinic. From a research perspective, we need that data on every patient. So that includes the control patients. But if it's part of the intervention, the control patients wouldn't get it. So we have to use Rapid Pro as a research tool as well, so that we can do AIM 3, so that we can understand if we can use it for anything predictive into the future. So when I say, or when we say it's clinical practice surveys and research surveys, that's what we're meaning when we say that. And clearly we have to be able to describe that in the grant.
So just to clarify, I'm not 100% sure that SWOG allows patient reimbursement, but we can find that out. And also to clarify with everybody, you know, the overarching plan for this would be to submit an R01 so that there would be financial support to the participating sites above and beyond what the CCD budget would provide. So for this particular study, if an R01 was obtained, there would be more financial resources provided to help the sites do that study.
So a question in the chat is, how will a person obtain the Rapid Pro? And so if you were on these calls, I don't know, in the past year, you've heard us first say, oh, we want you to definitely have an EMR that you can push this out. And what we know is that may be difficult for some practices. So what we have are some options for practices, in that we could send it out via a REDCap survey and then push those results to you. You could have it implemented within your EMR. The bottom line is we have to have a proactive way to gather the data, but we as researchers have to be flexible in our minds to work with practices to adopt that and figure out how it works in your practice, if that makes sense. So that was one question. It's not gone. And so then the point about check with patient advocates, we definitely intend to do that about patient burden on surveys. I mean, that is why we wanted to reimburse them, because we know this is a lot of surveying. And so that's the impetus and rationale for that, if we can do that. Let's see.
This is Joe, if I could chime in, Karen.
Yeah, go ahead.
As Rick Bangs pointed out, there is a pilot study about patient reimbursement that's being planned or ongoing. But my understanding is it's not a SWOG-wide thing. It doesn't preclude sites from doing it themselves through their own IRB, but certainly my experience, it's not something. I think the key is to sort of, Katie Arnold also pointed this out, I'm just reading the chat, that a key for patients might simply be to limit the burden of questionnaire collection and whatnot. Yeah.
So can I ask probably a naive question? Never mind. I'll ask it later. Never mind. I'll ask Dawn later. Okay.
I don't want to preclude it entirely. I think that we can continue to investigate, but that's my understanding right now.
I'll just say this. I wonder if many trials I anticipate, or I suspect, in SWOG and other cancer organizations are focused on treatment. And so a patient may be perceived as benefiting from that, or may have an opportunity to benefit from that. Here, I think the sell to a patient, for lack of a better term, is a little different. And so they still may benefit, but they have a greater research burden, I think, or I don't know, that's my perception. So I was just wondering, does that make it feel different? I don't know.
There may be a better rationale here. You're talking to someone who's all for leveling the playing field for patients. So I think we need to talk more. That's all. Yeah.
Okay.
I think you bring up a good point, and those are important issues. And I think it is very different than when the trial started out and it was like perceived as some type of enticement to get a drug. So I think we can definitely readdress that. I think one other issue, just in terms of interpretation of these surveys, is that it's super hard for a site to commit to saying that they're interested in being part of a study without seeing all the details and all the requirements worked out. And so one of the things that also came up was that as we do these studies and submit concepts, which are sometimes vague, that we really come up with a pool of site administrators, coordinators, and nurses to help us as we're moving concepts into protocols, to make sure that all of the details that are put into the final protocol are compatible with sites being able to actually do it. And so I think one thing that we're going to move towards going forward is to try to figure out a strategy to get more site involvement in that transition from concept to protocol. But we recognize that it's extremely hard for a site to commit to opening a study without sitting there and reading and knowing all the details. So that being said, thank you so much. We're very excited about this. It's a high priority area. And there's I think this is a great team and project to help advance the field going forward.
Thank you. And please reach out with any questions after today's meeting or feedback. We would love to hear from you.
Okay, I think we'd best move on. Christine Veenstra is going to present her concept on developing a dyadic model to promote guideline concordant colorectal cancer surveillance. Christine, over to you.
Thank you very much, and thanks everybody for your time today. Next slide. So for those of you who don't know me, I'm a medical oncologist at the Rogel Cancer Center at the University of Michigan and also an NCI-funded health services researcher. Next slide, please. So my research is informed by something that I've learned in my clinical practice, which is that informal supporters matter in cancer care. I know that a cancer diagnosis extends beyond the patient in front of me in the exam room to affect their spouses or partners, family members, and all the important people in their lives. And in fact, the Institute of Medicine highlights the importance of involving family and important other supporters in patient-centered care. Next slide, please. And there have been a number of studies that I won't show you today because of time limitations, but that have shown that married patients with cancer have improved survival and that supporters do impact clinical outcomes for patients with cancer. So what I'm interested in is whether informal supporters, such as spouses or partners, can improve receipt of guideline concordant surveillance among survivors of colorectal cancer. The reason surveillance is important for colorectal cancer is that even after curative intent treatment, about 40% of patients with stage 3 colorectal cancer will have a recurrence. If we find these recurrences early, we may still be able to treat them for cure, even if they're metastatic recurrences. And so guidelines recommend a 5-year regimen of intensive surveillance that includes physician visits, blood tests, imaging, and colonoscopy. It's 5 years of intensive care that can be difficult for some patients to receive in a period when a lot of people just want to be done with their cancer experience. So it's perhaps not surprising then that over half of the 1.2 million colorectal cancer survivors in the US don't receive guideline concordant surveillance care. Next slide, please. So to study this further, I developed an exploratory sequential mixed method study funded by a K award from the NCI that consists of qualitative and quantitative data collection to investigate the ways in which spouses and partners engage in patients' receipt of surveillance and whether that engagement from partners is associated with patients' receipt of guideline concordant surveillance. Next slide. So in our qualitative phase, we interviewed colorectal cancer survivors and their spouses or partners, and we found that partners engaged in many ways in patient surveillance care, and we organized these into 3 main domains. So psychosocial engagement, in which partners promoted patients' participation in surveillance. This could have been positive aspects of promotion, like cheerleading and encouragement, but it also could have been negative, like nagging and uses of force or threat to get patients to follow through with care. Partners expressed caring and concern for the patient, and partners participated in self-care in order to put themselves in a better position to help patients get the care they needed. Partners also participated in information seeking and dyadic communication, where they gathered information about surveillance, they stayed informed about the patient's surveillance test results, and they communicated with patients about surveillance care. Finally, partners participated in instrumental engagement, which was things like scheduling and reminding patients of appointments, going to appointments with patients, and accommodating the patient's preferences for how involved the partner should be, and managing responsibilities at home with caregiving, chores, things like that, so that patients were free to pursue surveillance care. Next slide. So one particularly interesting theme that emerged and that I highlight here in this quote from a patient and a partner was that patients' preferences for how engaged the partner should be were not always concordant with the partner's own preference for how engaged they'd like to be. And this can put partners in a tricky spot where they're trying to accommodate the patient's preferences while also feeling that they're involved in a way that works for them. So here, this patient basically told us he doesn't want his wife to come because she makes a fuss about surveillance and he just doesn't want to talk about it or think about it. And his partner, his wife, really wanted to be involved and says that sometimes she needs to badger him. She has to figure out how far she can push him before he'll get upset so that she can get the right amount of information for what she needs as well. Next slide, please. So we used what we learned in the qualitative phase to develop a dyadic survey of stage 3 colorectal cancer survivors and their partners. We recruited patients from our Rogel Cancer Center as well as the Georgia SEER Registry and the Billings Clinic in Montana. We had a good survey response rate and ultimately had 301 paired surveys from patients and partners. We asked patients and partners about partners' involvement in surveillance, and we asked patients about their receipt of various aspects of surveillance testing. Next slide, please. So in the survey, we asked partners about their engagement in surveillance using 3 key domains. So first, we asked partners how informed they felt about various aspects of the patient surveillance. We asked them questions about how involved they were in various aspects of surveillance. And then we asked them how aware they were of the patient's preferences around various aspects of surveillance. So what we found was that about half of partners want more information about surveillance. About 40% of partners want to be more involved in surveillance, although interestingly, only 20% of patients want their partners to be more involved. So that's an example of that disconnect. And about half of partners feel aware of patients' preferences around surveillance. The partners' engagement varied by their sociodemographic characteristics. So we found that female partners and those with more education felt less informed about surveillance, were more involved in surveillance, but felt less aware of the patient's preferences for surveillance. And another interesting fact was that about 25% of patients and 30% of partners reported that they didn't think that partners were being included in conversations with the patient's healthcare providers around surveillance. This is in line with findings with other research as well, where survivors of many different cancers have said that their partners aren't well included in their survivorship care. Next slide, please. When we looked at associations between partner engagement and patient receipt of surveillance, we found that a partner feeling informed about surveillance was not significantly associated with patient receipt, but I'll note that we didn't include an objective measure of partners' actual knowledge about surveillance. Interestingly, we saw that a greater extent of partner involvement was actually associated with lower patient receipt of surveillance. And what I don't know is if this is because when patients aren't getting recommended care, partners get more involved to try to encourage patients to get care. We certainly saw that come out in our qualitative work. But perhaps there may also be an unintended effect of a very involved partner actually pushing the patient away from care if the partner is more involved than the patient wants them to be. Our next finding was that greater partner awareness of patients' preferences was associated with greater patient receipt of surveillance. So when we took these findings together in the context of our qualitative findings, what we concluded was that having a partner who just does more of everything is not necessarily associated with better patient outcomes, but that having a partner who is engaged in a way that's concordant with what patients want may be an effective way of helping patients receive guideline concordant care and improve outcomes. Next slide, please. So we took that knowledge and developed a prototype for an online module for colorectal cancer survivors and their partners to use. The module is called Current Together After Cancer. And the goals of the module are to promote effective partner engagement that is concordant with patients' preferences and ultimately to improve patients' receipt of colorectal cancer surveillance. This work was supported by a Hope Foundation Seed Award, for which I am extremely grateful. So thank you to the Hope Foundation. Next slide, please. And here I'll show you just a few screenshots of what Current Together After Cancer looks like. So we start with the patient and partner viewing this together on their computer, and we give them some informational, some educational information about surveillance. Next slide, please. Then we ask the patient and partner separately to go through individual activities to elicit their preferences for how involved they would like the partner to be in the patient's surveillance, how involved the partner should be overall, and how involved the partner should be in specific aspects of surveillance care. Next slide, please. Next slide. Can you guys still hear me? I feel like you lost me.
We can still hear you.
Nope, we can still hear you.
Yes.
Oh, okay. So can you advance the slide? I don't see the slide changing.
We see it changing.
We see it changing on our end.
Oh, I wonder if the problem is on my end. Okay, now I can, let's see here. Okay, go back one slide to where it says compare your answers on the top. I think I might just have a lag. Problem may be the internet on my end. I'm sorry, I was almost at the end. So the slide that I see says communicating with your partner on the top. Is that?
Yeah, that's what we see. Do you want him to move forward?
That's fine. I'll just pick up from there. So this is to help dyads talk through areas where their preferences are different. We give tips for different aspects of dyadic communication with video examples. You can move forward to the next slide. Then we give examples of concordant and discordant preferences for each dyad. We ask the dyad to select items on which their preferences don't align to discuss further. Next slide. I think I lost it again. I can't see the slide. So I'll just keep talking because this literally is the last slide. Then we give tailored suggestions for conversation starters for each of the items the dyad selected and prompt them to talk through their differences and come to a consensus. So the next steps are that we're going to pilot test the prototype with 10 to 12 dyads at the Rogel Cancer Center. That should start in the next couple of weeks. We'll further refine content based on the pilot feedback. Develop a clinician-facing component of the intervention to provide clinicians with some information about who the partner is for their patient, how that dyad wants the partner to be engaged, and give tailored recommendations for how the clinician can best engage the partner, and then develop an R01 proposal for a multi-site randomized controlled trial of the multi-level intervention. So what I would love to hear from folks today is any feedback or suggestions on the proposed study. How useful do you think this will be for your patients and their partners? Any suggestions for what a clinician-facing component might look like? What would be helpful for clinicians to know? And in the future, if possible, I would love to partner with SWOG and with your sites on a randomized controlled trial of the intervention. So thank you. Sorry for the technical glitches.
So that was great. Thank you so much for presenting. It's so fantastic when we see our HOPE funds, really help with the development of a study. I know you're planning for an R01 in the fall, and we've talked about some of the logistics of that. If anybody has any comments now or in the future, I know I'm hitting some delays as well. Feel free to reach out, give, Christine direct feedback, reach out to us. And if anybody has any suggestions as this is being developed, let us know. I don't see anything in the chat box, but I don't know, Scott, if you see anything or if it's my internet.
No, I don't.
Okay.
But I would encourage folks to reach out to Christine if they have questions.
Yeah, there's one question that says, have you seen any cultural variation in the type of involvement?
Yeah, that's a great question. So in our survey study where we, assess this quantitatively, we didn't have as much racial and ethnic variation as we would have liked, despite the fact that we, worked with multiple sites. So there were trends towards underrepresented minority patients, those partners being less involved. They weren't statistically significant. I do think if we did this work in a larger sample with greater racial and ethnic diversity, we would probably see trends in that.
So thank you so much. I think, we'll reconnect, but we should probably move on to the next presentation. And speaking of HOPE Seed Awards, the next presentation, I don't know if you can all hear me or if I froze, but the next presentation
We can hear you.
by Randall Holcomb and Izumi Okado. Patient-centered video education intervention to improve rural cancer care delivery. I think they recently received a SWOG Hope Seed Award as well to help fund them with their work. So take it away.
So I'll just start and say thanks, Dr. Hirschman and Ramsey, for letting us present here. And I'm going to turn things over to Dr. Okado, who's a junior researcher here at the University of Hawaii Cancer Center.
Hi, today we'll be presenting a new study, Patient-Centered Video Education Intervention to Improve Rural Cancer Care Delivery. Next slide, please. We appreciate the funding from the Hope Foundation. Next slide, please. A brief background on rural cancer care delivery. Nearly 20% of the US population reside in rural areas. Rural residents have higher mortality rates from cancer, and many residents experience socioeconomic disadvantages and are more likely to be diagnosed with advanced stage cancer and report poorer health. Care coordination in rural areas has unique challenges, and these include limited or lack of access to specialty oncology services, long travel distances to care, and shortages of oncology providers. Rural clinics also often do not have the resources that are typically available in large academic centers or urban cancer centers. So many rural patients report challenges in seeking and finding information about cancer and cancer treatment. There are some notable gaps in the literature, and these include a lack of patient-centered care coordination interventions specifically designed for cancer patients in rural areas. In addition, understanding the impact of care coordination on specific delivery outcomes. Next slide, please. We've done some preliminary research. In the initial studies, Dr. Holcomb had developed the care coordination instrument, which is a survey designed to assess patients' perceptions of care coordination. It assesses care coordination both globally as well as across 3 domains: communication, navigation, and operational. In the initial studies, this survey was able to differentiate perceptions of care coordination across different practice groups. Next slide, please. We followed the initial studies with a larger study to validate the survey. In this study, we found that there are some factors that predict patients' perceptions of care coordination. Next slide, please. More recently, we started to look at differences in rural versus urban cancer patients' perceptions of care coordination. We presented a secondary analysis study at last year's ASCO quality meeting. In this study, we compared CCI scores between rural patients receiving urban-based care to those who are residing in urban areas. We found that rural patients perceive greater overall care coordination challenges, as well as challenges related to communication and operational. These suggest that communication and operational aspects of care coordination may be potential targets for improvement. We are currently collecting data in rural settings, sponsored by the AHRQ F32 grant. Next slide, please. Our present study has 2 aims: to assess rural patients' perceptions of care coordination, and to develop and pilot test an educational intervention. Next slide, please. Our hypothesis is that rural patients with cancer experience poor care coordination that contributes to adverse outcomes. An educational intervention designed specifically for rural patients will improve patients' care coordination experiences by enhancing knowledge and self-advocacy. Next slide, please. The objective of Aim 1 is to assess early-stage rural cancer patients' perception of care coordination using the survey instrument, and to correlate with delays in active treatment and a measure of self-advocacy. This is a cross-sectional survey design, and will recruit 60 adult patients with early-stage cancer who have completed adjuvant chemotherapy within the past 12 months. We'll recruit patients from rural areas in the Hawaii Island and Kauai. Next slide, please. Our measures include the care coordination instrument, modified patient self-advocacy scale, and patient reports of frequency of delays in active treatment. Next slide, please. Our analytic plans include examining correlations between the CCI scores and self-advocacy score and delays in active treatment. We will also compare data to urban patients from our prior studies. The outcomes for this aim include defining perceptions of care coordination for rural cancer patients and to confirm the results of our prior study. Next slide. The objective of Aim 2 is to develop and pilot test a TED Talk modeled patient video education intervention for rural patients with early stage cancer. This is a feasibility study, and it is a single-arm intervention with pre-post outcomes assessments. We'll recruit 20 adult patients with early-stage cancer prior to initiation of post-operative adjuvant chemotherapy. Next slide. The intervention is a TED Talk style patient video education program. It has 3 modules that are 12 to 18 minutes long, and they are presented by a faculty and a patient advocate. These 3 modules include cancer basics, care coordination basics, and how to be a self-advocate. The videos are preloaded on tablet device and can be viewed at the clinic or at home, and will administer pre-post tests in person prior to starting adjuvant chemotherapy and 6 months post-enrollment. Next slide. Our outcome measures include both qualitative and quantitative, and it will assess qualitative measures using directed interviews. We'll look at feasibility of implementation of the intervention and also patient satisfaction with the intervention. Next slide. We have both primary and secondary analysis planned. Primary analysis will focus on looking at qualitative assessment of the intervention and also quantitative impact of the intervention. Next slide. Laying the foundation for future research. The outcomes for this aim include to develop an intervention that can be utilized nationally for rural cancer patients, and to generate preliminary feasibility and efficacy results that will inform the design of a larger interventional trial. We are also currently looking at multi-level approaches to expand on the current pilot study in the future research. In the next slide, we have prepared a brief video clip as an example of how the video intervention will look like. Next slide, please.
I don't know if this is working for anybody else. Is this?
I don't think we have any
I
sound.
can't hear.
Yeah, so maybe
working.
just, okay, maybe just skip it.
And my apologies, the audio did not play through.
Next slide, please. Thank you so much for the opportunity to present our study. We look forward to your questions and comments.
So Izumi, there are some things in the chat, and I'll ask you. I'll present a few of those to you, and you can answer those. One of them that's really important was how we define rural. And so, do you want to? This is a topic of ongoing discussion at every one of our meetings. Do you want to field that one?
Yes, thank you for the question. We are defining rural based on both using our RUCC and RUCA codes. The Big Island and Kauai both fall under rural category under these codes. So that's how we're defining rural areas.
There's a comment about rural areas having a challenge related to good Wi-Fi and internet. And do you want to reiterate how we're trying to address that? That's definitely a problem in our rural areas in Hawaii, and something we've thought about in our study design.
Thank you. So our plan is to upload the videos on the tablet. So there is no need for Wi-Fi connections. Patients can just simply press play and will play on the tablet. So this intervention will not require Wi-Fi connection.
And there's also a comment about whether a measure of self-advocacy for rural populations might be the patient activation measure, or PAM. That was from Mark O'Rourke. I'm not familiar with that measure. Are you familiar with that measure, Izumi?
I'm not familiar with that measure. That's great. Question. We'll look into that.
So thank you both so much for presenting. It was great. We're super excited to hear the results and how this may lead to, you know, a future SWOG study assessing rural patients, which is clearly a super high priority area for SWOG and the NCI, but then also, you know, issues related to care coordination we may be able to learn across the spectrum. So thank you for your work and for presenting. I think we're going to move on to the next presentation.
Good morning or afternoon, depending on where you're located. I'm going to be presenting the preliminary results of a secondary analysis using data from the SELECT trial examining preference-weighted quality of life. Next slide, please. I have no disclosures, although I would like to thank Drs. Kraus and Meng for their support in this, in addition to the SWOG statistical team and James for advancing my slides, including this one right now. So the overall purpose of this study is to use quality of life data that was collected during the SELECT trial to examine whether there are differences in health-related quality of life across race and ethnicity, whether that is mitigated by education level. And we're, again, looking at the population of men that were part of this trial. We're curious to know whether this might be true because we observed differences in incidence and mortality rates of prostate cancer and more broadly health in general. And the theoretical idea here is that if a person assigns higher utility weight to a given health state, they don't mind being sick as much as another person, which may mean they're less motivated to seek care. And conversely, if a minority patient or patients in general assign lower utility weights to a given health state, that may mean they dislike being sick more, which could be an indication that there are social determinants of health which are attenuating their ability to access resources. And I just, again, want to remind you that these are only preliminary results and that the meat of the statistical analysis is ongoing. Next slide, please. So I just want to put into context the motivation for conducting this analysis. An instrument called the EQ5D was used to show that there are differences in the utility-weighted health-related quality of life along racial and ethnic lines. And we're using an analogous instrument to the EQ5D in the present study. We also know, as I mentioned, that there is a difference in incidence, treatment, and outcomes by race and ethnicity in the United States. And there are also differences, there's a lack of research examining how health-related quality of life is affected in cancer prevention efforts specifically and also more broadly. Next slide, please. So briefly, I just want to talk about the SELECT trial, which is the source of this data, although the details of it are not necessarily relevant to the study. Vitamin E and selenium were considered as possible preventative measures for prostate cancer, and in 2001, men were enrolled into the trial, and one of the main goals of the trial was to recruit minority patients, and as you can see, of the 35,000 men who were recruited, 21% were minorities. Health-related quality of life was considered to be a key endpoint in the trial, aside from the prevention effects of the supplements. And in order to measure health-related quality of life, the SF36V was chosen as an instrument. This was only collected for a subset of patients, particularly those at community clinical oncology programs and also some Veterans Affairs Cooperative Studies program sites. Next slide, please. So the instrument, as I mentioned before, was the SF36V, and it is a minor variation on a well-known instrument called the SF36, which measures health-related quality of life across 8 domains. And an aggregate score can be generated from these 8 domains, but any 2 overall scores can't be compared across people because the scores are not ordinal. In other words, we don't know how people feel about a given score, we just know what their score is. And the SF36V has been validated prior to the study that we're conducting here to have all the same properties as the SF36, and so for our purposes, we'll consider it to be the same survey in the context of this analysis. Next slide, please. So the SF6D is a score that can be derived from the SF36, and it defines only 6 domains of health, which I'll show on the next slide. And it also defines 8,000 health states. So for a given SF36 response, which, as I mentioned before, is not comparable to any other SF36V responses, the score can be converted to an SF6D score, which is ranges from 0 to 1, and any S to SF6D scores can be compared. A higher SF6D score is unambiguously better than a lower SF6D score. Here we define 0 to be death and 1 to be full health. May I see the next slide, please? So as I mentioned, there are 6 domains. This is 2 fewer than the SF36, and it helps to limit the scope of health states that can be defined. And each domain asks several questions of a person, and a person will rate how they feel about their current health in a given domain. Next slide, please. So in this analysis, we look at a subset of the data that was collected from the SELECT trial. And as I mentioned, only a certain subset of all participants in the trial provided quality of life data, and then only a certain subset of those participants actually provided enough data to be considered in the analysis. So we needed data to be available at baseline, and then at least one of the first 3 follow-up years, which would be years 1, 3, and 5. So we collected those data and then derived the SF6D score from the SF36V responses. And as a reminder, we want that score so that we can compare between different respondents how they value the quality of life given their health state. And what I'm going to show on the next slide is the unadjusted baseline data and the confidence intervals that we have from them. Next slide, please. I preempted myself. First, I'm going to show you the characteristics of the respondents, and then I'll show you the results. So I want to highlight here at baseline, so that would be the first column in the top section. We see that there is a very large percentage of non-Hispanic Black and Hispanic participants. And this is particularly unique because we'll have enough data to make good, strong statistical inferences. And as I'm sure many of you are aware, it can be difficult to recruit a diverse group of participants. I also want to note that the populations are relatively stable over time. So we see only minor variation in the mix of respondents in years 1, 3, and 5. Next slide, please. So here we have the unadjusted SF6D scores. And so since 1 is the best score, you can see in the baseline column that the Hispanic respondents have the highest quality of life, and their confidence interval is non-overlapping with the non-Hispanic White and non-Hispanic Black cohorts. This is a particularly interesting finding because prior to the adjustments for age, education, income, other demographics, which will be done at a later time, we're already starting to see that there's a possible meaningful finding among these data. So if you could go to the next slide, please. This is just a visual representation of what we observe at baseline and the 3 additional time points. And we see that in addition to there being a downward trend among all of the subgroups, there are also apparent differences between subgroups at the available time points. We don't expect that once we control for demographic data, the overall trends will change, although it's possible that the magnitudes of the differences will change. And so the goal is to do a multiple linear regression. So we can say all else equal, given equal income, age, education, etc., what are the underlying differences by race and ethnicity and health-related quality of life? Next slide, please. So from these preliminary data, as I mentioned before, we see non-overlapping confidence intervals at the 95% level between Hispanic versus White, Hispanic versus Black, and White versus Black subgroups. And we also see that there's an apparent trend where scores are decreasing over time. Next slide, please. So this sets us up well to ask a few interesting questions and focus our research for the rest of the analysis. We'll be using multiple linear regression to examine changes in health-related quality of life over time, controlling for many of the demographic variables that were collected in the SELECT trial. And in particular, we'll be asking what is driving the high baseline scores among Hispanic men and the ostensible change in health-related quality of life among Hispanic men over time. And then conversely, what is driving the low baseline scores among Black men? In particular, I think this raises an interesting question about how to provide culturally competent care and how caregivers can accommodate differences in utility-weighted health-related quality of life. If, for example, you know that for a given health state, a Hispanic patient may have a higher value associated with that, I think it's important for caregivers to consider how to interact with that patient and what kind of care to provide. I have no further slides, but I'm happy to take any questions. Thank you.
Thanks, that was
Thanks so
great.
much. Go ahead, Scott.
So that was great. Really nice to see use of the select population for new studies that can give us insights into social determinants and issues of quality of life affecting minorities especially. So thank you for doing that, and we'll invite you to come back and present further results at another meeting.
Thank you.
So I know we're running towards the end of our allotted time for our meeting. We're going to keep going for those of you who can stay on, and I hope you can, but if you have to move on to another meeting, we of course understand. So I will move on and quickly move through a concept that's in very early stages, and I'll say right up front that I'm hoping that folks who are able on the call who are able to provide feedback to me on this concept, I'd encourage you to reach out so that we can get this started. So I'm going to present on a concept for screening for social determinants of health in oncology practices with a focus on potential benefits and feasibility. Next slide, please. So social determinants of health are, as most of you know, widely recognized as having important impact on care and outcomes. And there are many national and local efforts underway to promote screening for social determinants as part of routine clinical practice. However, the implications for cancer patients and oncology practices has not been studied, and the implications are unclear. Next slide. As I mentioned, their national groups are calling for incorporating social determinants into care pathways, as is evidenced by this New England Journal Catalyst article. Next slide. I think there are a number of compelling reasons to screen for social determinants of health in oncology practices. When patients are diagnosed with cancer, it's a time of unique vulnerability for the patient and their family. As we all know, social determinants can directly impact patients' ability to participate in shared decision-making. It might impact their time to start and likelihood of completing care. It might affect their functional status during and after treatment. And it could impact family stability, as we're learning with our financial toxicity work, including loss of income and food and housing instability. So it's possible that a proactive screening and intervention might prevent years of downstream problems. Next slide. So this is a nice figure that we adapted from a recent journal, a recent publication in Cancer, that shows the continuum of social determinants. When patients present to oncology practices, many of the things on the left-hand side of this slide, such as structural inequities, social injustice, the institutional environment, and living environments that all impact individuals differently, are already set. And so at the point of contact, it's a matter of really understanding risk factors and the patient's current situation if we're going to be able to intervene on social determinants to impact care and outcomes. Next slide. There are many tools that have been developed to screen for social determinants, and practices and systems are adapting tools to their own institutions and their own needs. And this is a sample of a tool that's used by a health system here in Washington State. And you can see the range of questions that patients are being asked. I should say this is not limited to an oncology practice. This is focused mostly on primary care. So you can see that the questions talk about food insecurity, housing insecurity, being able to cover utilities, education issues, violence in the home, self-care, and issues about financial problems and ability to continue with medications that have been prescribed. Next slide. So now I want to talk about the concept of what we might be able to do within the SWOG. more broadly throughout the NCORP system. This is a schematic that many of you know showing the LUMMAC protocol, an umbrella trial where patients are screened at diagnosis, and there's molecular profiling of the tumor sample. Based on the findings, patients are put into different trials comparing new therapies versus usual care. Next slide, please. Currently, the screening and support for social determinants of health in oncology is highly variable and really based on a model where it's the patient's responsibility to address the social determinants that they face, and that it's the practice's responsibility to provide care. We're proposing a centralized system where screening occurs in the practice and the practices are able to act on what is found on those screening questions to address the social determinants as a part of a more holistic care pathway for their patients. Next slide. We think this needs to be done in the context of clinical trials, and so what we're proposing is an umbrella trial for social determinants. So instead of screening cancers for genetic variants, we would screen patients for social determinants. And based on what is found on those questionnaires, patients would be put into studies that would compare new interventions to address those specific social determinants versus usual care. And the framework for this allows multiple studies to happen simultaneously, both within clinics and across the entire system. It also allows for rapid modification based on learnings in terms of specific interventions that could improve social determinants as the study is moving forward. Next slide. Now, I've had many discussions with oncology practices about this, and we're under no illusions that this is a massive effort, particularly for community oncology practices. That the barriers are many, including needs for clinic staffing requirements, training and education of staff, access to resources to address social determinants, most of which are not currently part of oncology practices, and monitoring for social determinants over time. These are just a few of the barriers that we're aware would be significant issues for oncology practices who wanted to undertake a screening program for social determinants. Next slide. With that in mind, we're gathering a number of partner organizations for this study who have extensive experience with addressing social determinants for patients with cancer. All of these that I've listed here have been working with SWOG in the past on prior trials, primarily around the area of financial toxicity, but they have capabilities that extend beyond financial toxicity. And I should note that we are in the process of finding other service providers who can address these social determinants as well. Next slide. So in terms of study objectives, these are our currently proposed objectives. First is to develop an oncology-specific social determinants of health screening tool for newly diagnosed patients. To implement that, the second objective would be to implement that tool in a pilot setting at interested community oncology sites. We would want to measure the adoption of that screening tool, understand the prevalence of people presenting to practices who have deficits in social determinants, and understand the needs by the practices and the patients to help us design interventions. We, of course, want to compare outcomes of patients who have social determinant needs versus those without. Next slide. So the proposed schema for the study would be to start to evaluate these outcomes: time from registration as a new patient to initial treatment, the likelihood of completing therapy at initially planned dose and schedule, patient-reported outcomes, for example, the FACT-G or SF-12, many others we could look at, financial toxicity, and of course, survival. Again, this is a pilot where we would want to collect a broad number of outcomes to really understand the situation. Next slide. So our research agenda moving forward, and I've had a number of discussions with NCI about this, and they'll be ongoing throughout the summer. We're hoping to begin discussion with SWOG clinics and patient advocates regarding the feasibility of screening for social determinants among newly diagnosed cancer patients. So those of you who are on today, feel free to reach out to me so I can start getting your input. We'd like to develop an oncology practice-oriented social determinant screening tool, and we recognize that one tool may not fit all practices, and we may need to have modules that allow adaptation to specific clinic needs, including not only the questions, but how it would be administered. We are in the process of developing agreements with external partners that have expertise in this area. As I mentioned, the three, and we have more in the works. And our hope is that as soon as feasible, that we're able to launch a pilot study that's aimed at determining the feasibility of screening and understanding early effectiveness. Next slide. That's all I have for that. I just wanted to make folks aware that we're in the early planning stages for this very ambitious study, which I think will be timely and very impactful for the NCORP program.
So thank you so much. I think there was, first of all, it's incredible that so many people were able to stay on. There was a question about participants in studies like this sometimes being shocked that they qualify and, to participate and how that makes them feel. So, really a point to just think about the language that we use and what it means and all of that. And I think a lot of that, I would imagine, will go into the pilot testing.
There are so many issues that we have to be attentive to when we start asking questions of this nature. And they cut into things like distrust of healthcare providers, shame, nervousness about whether asking these questions is going to impact their care. It's a really important issue, and we have to be very sensitive as we approach it.
Can I ask a question,
So I think,
Dawn? Oh, sorry, very quickly.
Yeah.
In SWOG, we collect virtually no social determinants of health beyond race, ethnicity, and unique among the groups insurance status, I think. It may also be time to start thinking about broader collection of very simple things like income and education. Anyway, quick point. Outside,
I think it's super important, and I think it would help us down the line in terms of interpretation of some of our results that we probably misclassify sometimes as being attributable to one thing when really it's attributable to something else. So I think it's really important, and I think it's probably really important that we think about that along the lines of developing this other study to sort of go hand in hand with data collection. I think with that, we're way over. I know Matt has presented his study several times. He's working on a concept submission. I think we'll have him lead for our next call in terms of the progress that he's made. And really thank everybody for staying on a little bit over to hear all of this. We really want feedback as much as we can get on these studies. And I don't know, Scott, if you have anything else to say. We're going to plan our next call in the next 2 months.
Yes, so for those who weren't able to present today, including Matt, we're going to give you an opportunity at the next call. And we really encourage for everyone who attended to provide feedback to the presenters today. They're eager to hear your comments. And you know how to find me if not them, and I can certainly get comments to them if that's the best way to go.
Great. Well, enjoy the rest of your meeting, everybody, and special thanks to Joe and Barbara and everybody who helps, and Patricia, everybody who helps so much on the design implementation of all the studies that we do.
Have a great rest of the meeting, everyone. Bye-bye.